Welcome to EcoMap, the practical, easy, and above all, useful ultrasound for general practitioners. Today we're going to talk about hernias. That's our topic. Hernia of the linea alba, something that's very useful, very common, and above all, very easy to do in general practice. So I thought it was a perfect fit for this channel, EcoMap. And today's clinical case comes from a 64-year-old female patient. Just a reminder that right now, ultrasound training is available, and the link is in the description. It's a course designed to help you get comfortable with an ultrasound machine, even if you've never touched one in your life, even if you're totally intimidated by the keyboard with all its buttons. We're going to cover everything in this course, and by the end of it, I guarantee you'll know how to handle an ultrasound machine. It won't be intimidating for you anymore, and you'll want to learn so much more about the amazing world of ultrasound. I invite you to click the link in the description. So, as I mentioned earlier, this clinical case was brought to us by a 64-year-old female patient. What's most interesting, especially with the COM apps, is that these are real cases I found interesting during my day, and I talked to you about them directly at the end of my consultation day. What's interesting is that this patient came in for a consultation, not for that at all. In fact, she came in for a urinary tract ultrasound, but she specifically came for this urinary tract ultrasound. Bladder empty. So actually, I couldn't really offer the patient much, so I started to explain to her that, well, we really wouldn't be able to do a proper or useful ultrasound for her under these conditions, and that she would need to come back. And then the patient started telling me an absolutely unbelievable story. She'd had surgery for a hernia of the linea alba a few years ago, and then another operation for an incisional hernia a year ago. And for a year now, she's been struggling with her surgeon, telling him that she has a mass in her epigastric area, that it hurts, that it's bothering her, and the surgeon keeps telling her, it's fine, it's fine, it's fine, there's nothing wrong, everything's okay. No, I'm not going to prescribe you an ultrasound. No, it's pointless. There's no point in doing that. And so the patient kindly asked me, since they couldn't do it for her urinary ultrasound, if I would agree to just take a quick look with the probe on her epigastric area to see whether or not she was right and whether or not there was a hernia. So, well, yes, of course, there was a hernia. And so this case is going to be a perfect one to talk a bit about how we do it, what we see, and what we find. It's easy, it's useful, but you have to do it properly. As always, you always have to take multiple views. Here we have a transverse view. Here we have a sagittal view. Here we have a slicing view of the patient. And here we have a view along the axis of the patient. The small hyperechoic line is the epidermis. Below that is the dermis. All of this area here is the hypodermis, of course. The hypodermis with its slightly wavy strands, which we can see in both directions. Just below, our famous white line. Let me remind you that since we're in the transverse plane, our white line on each side, what do we have here and here, which we could see if the view were a little wider? The rectus abdominis muscles. The rectus abdominis, the abdominal muscles, which are connected to each other by a very visible band on ultrasound, perfectly easy to see, called the white line. Below that, we have our peritoneum. And here, since we're positioned very high up, we have the left lobe of the liver, same view but this time in the sagittal plane. The dermis. The hypodermis, this white line which, this time, is aligned with the patient's axis in the sagittal direction, the peritoneum, and here the liver. So here, it's obvious. You can immediately see that this white line is interrupted. It's interrupted. Interrupted by what? By a hernia. A hernia, this typical shape that you absolutely need to look for, which is, if I may say, pathognomonic of a hernia, of the linea alba hernia in general, but especially of the linea alba, because it's very, very easy to see. Here you have a mushroom-shaped form like this, which you can see extremely well on the sagittal slice here as well. The slices always look a little different between the transverse and sagittal views. That's normal. Here, this is a typical appearance of a linea alba hernia. If anything, as we'll see later with the dynamic images, it's slightly multi-lobed. That's normal because this is a surgical revision. This is already the patient's second operation. Often, you'll only have a single hernia sac. Here we have two. With dynamic imaging, I'll show you a bit how we look for a linea alba hernia and what it looks like. You can always see that with dynamic imaging, it's always much easier. Ultrasound. You can see that with the patient's breathing, this sac, which is mobile, becomes clearly visible. And now, when we switch to the sagittal plane, you need to learn this movement, and I teach it to you in the training. Here, you can see the hernia sac. Same thing, it's still mobile with our linea alba on each side and the hernia sac in the middle. And the central part, which we call the neck, is important to measure, because if the neck is very tight, there's a higher risk of strangulation. If the neck is wider, the hernia will be more mobile and less likely to become strangulated. So how do we look for it? We're going to locate our linea alba. As I explained to you, it's very easy. You just position yourself right below the xiphoid, at the base of the sternum. We identify our hypodermic tissue, and just below that, there's a highly echogenic line that's very easy to see. You can't mess this out. We're going to use an elevator method. Shall we start? Very high up. We're going to move down little by little. Down, down, down. And we're going to try to find a spot where this linea alba is interrupted. You'll see it's very easy to spot. You'll be able to spot it easily in the video. We're moving down, here's our white line. We keep moving down, keep going down, and there it is. The interruption and the white line appears. We've found our reunion point. It's really not complicated. If you master the elevator technique, if you really understand the different layers, and if you found your linea alba, which just reappeared here because we kept moving down, let's move back up a bit toward the hernia area, and there you have it. Our white line interrupted by this hernia. So this is a cut that's easy to perform and easy to learn. Another interesting thing you can have patients do is the Valsalva maneuver. You'll see that it's quite informative and sometimes helps a bit to visualize the contents. And I have to admit, with this ultrasound, I had a hard time deciding whether it was digestive content, whether there was an associated collection. Since this is a surgical reoperation, it's possible there could be a collection, or if there were other images. It was a bit difficult. I had a Valsalva maneuver performed, and you'll see that we can see this multi-lobed hernia very, very clearly, even if it doesn't really jump out at you like this on a still image. You'll be able to observe that here we have a dehiscence, and here we also have a second dehiscence as well. So there you go. You can see that it's fluid-filled, you can see that it's mobile, especially here, very mobile with the impulse. As soon as we ask the patient to blow while pinching her nose, we can see the impulse here, and here. So this hernia sac is just waiting to come out. It's very mobile and not strangulated at all. You can see that the contents are fluid-filled. We could already see that visually earlier. On the static scan, we could also see a posterior reinforcement. We see some hyperechoic images that are a bit hard to interpret. Could it be digestive gas? Could it be a mesh that was placed to prevent hernias, since this was a hernia repair? Or could it be a foreign body? The patient will undergo a follow-up MRI to better characterize the hernia sac, because she will have to go back for surgery a third time for another repair. So we notice that there's no clear boundary to this sac, hernia sac, which makes me think there's probably some fatty tissue from the intestinal fat, but there isn't any actual intestinal loop since we don't really see the intestinal wall appearing in this view. Usually it's much more obvious than this. Now here's a second video, still during Valsalva, same thing. This time you'll see it on a slightly different slice. You can see the hernia coming out very, very clearly. There you go, the patient is exhaling. So this is a very interesting test to do, because when you have some doubts about very small hernias, now this one is actually quite significant, but for much smaller and harder to see hernias here, you might think, you see, we saw it a little bit in the video, that there's actually a bowel loop that manages to slip in when the lady exhales. Maybe here as well, which could explain a bit of digestive gas. So when you have a very small hernia, it's really important to do these maneuvers, especially in the inguinal area, but also at the level of the linea alba, because it will make your exam more sensitive and much easier and more visual. It always makes for nice images, and we like nice images in medicine and in ultrasound. Let's take a look here together to see. It seems that when the patient exhales, we can possibly make out a bowel loop here, especially when she relaxes. Maybe here, a bowel loop, probably, which could explain this fluid image and especially the gas, since, of course, the intestines will contain both some fluid and some gas. So I'm sure this clinical case interested you. As always, I invite you to like the video. Subscribe, click the link in the training to learn more about ultrasound, to learn how to use all the little features of your ultrasound device, and to develop your medical practice. I'll see you very soon in another video on EcoMap.
Bye.